So very good morning, one and all. So this morning we have a very first session of the day, and that is the free paper external eye disease. So we will limit with the time, and the time for speaker is 5 minutes. So please remember that. And with me, we have Dr. Niraj is there, Dr. Ashok is there, and myself, Dr. Lomi. So to begin with, I will call upon the first speaker, Dr. Shalin Shah. He will be speaking on bilateral OSSN in anhidrotic ectodermal dysplasia syndrome, battling 3 devils at once. The timer, please.
So, good morning. Today we'll be discussing a atypical presentation of bilateral OSSN. So, let's have an overview of excuse me, it's not moving ahead. Okay, yeah. So, anhidrotic ectodermal dysplasia, it's a congenital disorder affecting the X chromosome, the EDA gene, ectodermal dysplastic gene on the X chromosome, and it's an X-linked recessive disorder, which mainly affects the ectodermal components, that is the hair, that is hair loss, anhidrosis, that is loss of sweating, and teeth involvement. Characteristically, it does not involve the nails, the salivary glands, or the palms and soles, as seen in palmoplantar keratoderma. So we had a young patient walk into our OPD, a 14-year-old, complaining of bilateral reddish mass on the temporal conjunctiva. As we can see in the picture, there is almost symmetrical looking elevated lobulated mass with sentinel vessels, internal vascularity. In the right eye, it was involving around 8 clockas of the limbus. In the left eye, it was involving around 6 clockas of the limbus. External examination of the patient showed shiny hair with a receding hairline, loss of sweating on the face, abnormal teeth, and a familial history showed similar complaints of ectodermal dysplasia in the younger brother, but not in the youngest sister, which suggested the X-linked recessive pattern. However, none of the parents or any cousins, first or second degree relatives were involved. Examination of the patient showed good best corrected visual acuity 6/6 with significant against the rule astigmatism. Movements were full and free. The patient had severe dry eye with 5 and 4 millimeters on Schirmer's test. Now the lesion was evaluated first using ASOCT, which showed abrupt transition with hyperreflective epithelium. Characteristic scleral cleft was present as shown by the green arrow, which suggested a carcinoma in situ with sparing of the sclera. And these findings were seen bilaterally, suggestive of a neoplastic etiology. A reverse impression cytology was done at our center, which showed increased nuclear to cytoplasmic ratio with atypia, nucleoli, and this was suggestive of a bilateral OSSN carcinoma in situ. Now our first challenge was whether to go for a surgery in a bilateral case with severe dry eye or go with a conservative management. So we went ahead with a topical immunotherapy, that was interferon alpha 2b drops, 1 million international units 4 times a day. At 4 weeks, there was no change in the size of lesion. Why? This was our first challenge. So in retrospect, when we reviewed the literature, the disorder EDA gene typically acts by the immune pathway NF-κB, and the immunotherapy interferon also activates the same pathway to have the antineoplastic effects. So the mutation actually did not allow the interferon to work, and hence our immunotherapy failed. So a challenge ahead was, should we go ahead with a topical chemo or now start surgery? And since he had a very severe dry eye disease, there was a high risk of keratomalacia. So under hourly lubrication, we went ahead with low-dose topical mitomycin C 4 times, 1 week on, 1 week off. At 6 cycles, at the end of 6 cycles, we had a very significant response with regression in the height of the lesion and also the limbal clock hours. Now, after 6 cycles, the patient had started developing punctate staining with mitomycin, so we went ahead with a surgery. Our surgical challenges here were we would not be able to do an allograft of conjunctival autograft from the other eye because it was a bilateral tumor. So we went ahead with a white margin excision, epithelectomy, cryo, and amniotic membrane with BCL with regular 3-day follow-up. And finally, we did manage the dry eye with hourly lubrication, preservative-free. We could salvage around 6 clock hours of limbus in both the eyes, and the vision was salvaged. The histopath was as shown. We can see that the basement membrane is intact at all points, but there are neoplastic cells in clusters and forming the squamous keratin pearls, suggestive of an OSSN. Finally, at 9 months, this is the patient. He has a healthy limbus, healthy surface, and he has a 6/6, that is 20/20 vision, preserved vision, and the astigmatism has also significantly come down. So, thank you. This is the first reported case, so in the literatures, we don't have any other studies or case reports to discuss. Thank you.
How would you manage in this case limbal stem cell deficiency after doing this surgery?
Sir, actually, we had counseled the patient that there may be a requirement for alloslet in the post-op period. At 9 months, still we have a healthy surface, and we have not gone ahead with a limbal. We could salvage around 6 clock hours of limbus in both the eyes following surgery. So right now we are just observing the patient because the younger brother also has a similar condition. So taking an alloslet from the brother would may cause a problem in the brother. So right now it's a wait and watch game. In case there is no recurrence, we can maybe at 2 years follow-up, we can plan an alloslat from the parents.
Very rare case, Dr. Shalin. What does the literature say? Is this the first reported literature? And what is the difference with other features, like in case of xeroderma pigmentosa? And how do you expect that recurrence rate will be there?
So actually, the margins were clear, the base was clear, and there's no, I mean, the ASOCT till now, it doesn't show any epithelial changes any longer. So we are not expecting a recurrence, but these are very unpredictable cases. I mean, they can have a second primary as well because it's an immunodeficiency state. So I think it's just a wait and watch game right now with monthly follow-ups and regular screening of the ocular surface and regular screening of the siblings as well because there's a chance of malignancy in them.
One last question. How are you going to follow up with that sibling is he have also got a similar lesion, or you want to follow up in?
So the sibling, the younger brother, has severe dry eye, but he doesn't have any conjunctival lesion as such. This patient was actually, his first follow-up somewhere else was noted as Herbert's Spitz, and he was treated accordingly. So right now that's the only changes we are looking for in the younger sibling, and both of them are on follow-up, regular follow-up every monthly.
Okay, thank you.
Thank you, sir.
Just one more question. Apart from OSSN, any other systemic neoplasia known to be present in ectodermal dysplasia syndrome?
No, sir. The anhydrotic ectodermal dysplasia, the ocular manifestation described are nasolacrimal duct obstruction, punctal agenesis, and sometimes entropion, congenital entropion. Okay. But OSSNs or any other conjunctival intraocular neoplasms are not yet described in the literature.
Okay.
Thank you, sir.
So moving on to the next speaker, if we have Dr. Tanvil Mittal is here. Yeah. So you can please come up and share your slides. She will be speaking on the eye turns against itself, inflamed and tethered, a rare case of ocular cicatricial pemphigoid.
Good morning, sir. How are you?
Good morning.
First one? No, it's the second.
Good morning, everyone. My name is Dr. Tanvi Mittal. I'm from Sarojini Devi Eye Hospital. I'm a second-year postgraduate. Today, the title of my paper is The Eye Turns Against Itself, Inflamed and Tethered, a rare case of ocular cicatricial pemphigoid. Ocular cicatricial pemphigoid is a form of mucous membrane pemphigoid that features a chronic, relapsing remitting bilateral cicatricial conjunctivitis. It's considered a rare disease with an incidence of about 1 per 10,000 to 60,000. Oral mucosal involvement is also seen in patients of mucous membrane pemphigoid, followed by skin and other lesions in the trachea, esophagus, pharynx, larynx, etc. But ocular cicatricial pemphigoid predominantly is a rare disease. It commonly affects females in a 2:1 ratio over males, and the age of onset is about 60 years of age and older, with no racial or geographical predilection. Coming to our case, a 51-year-old female who was otherwise healthy presented to the OPD with gradual progressive decrease in vision since 3 months, which was also associated with pain, redness, and discharge from both eyes. She also gave history of bilateral conjunctivitis 1 month post right eye pterygium excision surgery, which was performed 2 months back, for which she used eye drops moxifloxacin 0.05% for 2 months. There was no history of ocular trauma, and no other systemic comorbidities were noted in her. On examination, the vision was perception of light in right eye and hand movements in left eye. Both eyes showed matting of eyelashes due to discharge. Conjunctiva showed chemosis, congestion, and symblepharon was also present. Corneal edema was seen, because of which the other details of the anterior segment were not appreciated. According to our clinical examination, we made a provisional diagnosis of a stage 3 ocular cicatricial pemphigoid. Further, we evaluated the patient by doing a B-scan ultrasonography of both eyes, which was normal. Vitals were also within normal limits. Systemic examination was unremarkable. No other systemic lesions were seen in the patient. For further investigation, we performed a conjunctival biopsy from both eyes, and it was sent for microscopic examination as well as direct immunofluorescence testing. The biopsy revealed subepidermal bullae and was devoid of epithelium. The diagnosis of OCP was further confirmed by direct immunofluorescence testing. This patient was further treated conservatively and was referred to a rheumatologist for the management and advised to follow up with us. Coming to our discussion, ocular cicatricial pemphigoid is a chronic, progressive, potentially blinding systemic autoimmune disease, which is thought to be due to a type 2 antibody-dependent hypersensitivity response seen against the hemidesmosomal epithelial membrane complex in the conjunctival basement membrane. This autoimmune response is usually seen when patient has a genetic predisposition and is exposed to an environmental trigger. The hallmark of OCP is a progressive cicatrization of the conjunctiva, which can further lead to progressive symblepharon, ankyloblepharon, pharyngeal shortening, potentially leading to blindness. The gold standard for diagnosis is a judicious conjunctival biopsy with direct immunofluorescence testing for IgG, IgA, IgM, and C3. Positive staining usually reveals a linear pattern in the basement membrane zone of the conjunctival epithelium. But about 20 to 40% of patients may have clinical signs of OCP but have a negative biopsy result, which does not rule out the diagnosis of ocular cicatricial pemphigoid. These patients most likely only have ocular disease, as with our case, as a positive result is much more common in patients with ocular, skin, and oral involvement. Negative results usually could be due to incorrect biopsy technique, concurrent quiescence, or even a disease burnout. Thus, OCP poses a challenge both for diagnosis as well as management, as most cases remain undiagnosed until the late stages because of the non-specific signs and symptoms till the stage of stage 3 symblepharon. Coming to conclusion, an exclusive presentation of ocular cicatricial pemphigoid without any systemic manifestations is very rare. It can also be confused with other diagnoses like Stevens-Johnson syndrome, Sjogren syndrome, graft versus host disease, and other conjunctival scarring disorders. Of those patients with mucous membrane pemphigoid, patients with ocular cicatricial involvement have a worse prognosis than those with skin or oral involvement. Thus, early diagnosis and management are imminent to preserve vision. The diagnosis requires high level of clinical suspicion, especially in cases of chronic, recurrent, unexplained conjunctivitis to prevent the complication of blindness. Management involves a multidisciplinary collaboration between ophthalmologist, dermatologist, and rheumatologist. Thank you.
How would you follow up these cases?
So for this particular case, we had advised follow-up monthly. After she reviewed with the rheumatologist, they started her on methotrexate treatment, and we had advised follow-up 2 weekly. But actually, the patient passed away. We got to know when we followed up the patient, we got to know that the patient passed away, but we couldn't elicit like the cause of the death. A 2 weekly follow-up should be.
You must have done the literature reviews or any such cases without any systemic association?
Yes, sir.
How many?
Okay, get it published.
Yes. Thank you.
Thank you.
Next speaker, Dr. Kritika Vedeveli. She would present the ocular scar from an invisible war, a clinical study on ocular Stevens-Johnson syndrome.
Good morning, sirs. My name is Kritika. I'm from Regional Eye Hospital, Kurnool. So my presentation is on a clinical study on ocular Stevens-Johnson syndrome. So Stevens-Johnson syndrome is a rare and severe acute blistering disease that affects skin and at least 2 mucous membranes. It is most commonly triggered by drugs and infections. Ocular involvement occurs in up to 50 to 80% of cases and contributes significantly to long-term morbidity. So my objectives are to evaluate the ocular manifestations in patients with Stevens-Johnson syndrome spectrum of disease, to assess visual outcome and complication during follow-up, to highlight the importance of early ophthalmic intervention in prognosis. So this is a prospective observational study done in Government General Hospital, Kurnool, of 10 patients clinically diagnosed with Stevens-Johnson syndrome spectrum for a duration of 1 year. So parameters assessed were visual acuity at presentation and follow-up, ocular surface changes were noted, corneal involvement and adnexal complications were noted. So interventions that we have done are mostly medical management, corticosteroids, cycloplegics were given, vigorous topical lubricants, antibiotics, and prevention and treatment of symblepharon. So these are the cases who have developed Stevens-Johnson syndrome. The first case was developed secondary to phenytoin. Second was developed secondary to carbamazepine. Third one was secondary to painkiller. The patient was not sure of which tablet it was. This fourth case was secondary to ciprofloxacin tinidazole combination. Fifth case was secondary to Ayurvedic medicine, and she has taken this Ayurvedic medicine for some skin lesion. And case 6 was developed secondary to cotrimoxazole. Case 7 was secondary to amoxicillin. And all these 3 cases did not have much ocular complications, only skin lesions were present. So this was secondary to fluconazole. Case 9, there was no reason, idiopathic. And case 10 was secondary to oral diclofenac. So in her hospital, 10 patients were diagnosed as spectrum of Stevens-Johnson syndrome during 2024 to 25, in which patients with ocular involvement were only 8. So on follow-up, we have done follow-up for over 1 year. we can see the epidermal peeling has reduced and all the healing has started. So in acute phase findings, 80% of them had conjunctival congestion, 37.5 had pseudomembrane formation, 25% had epithelial defects, and the least were mebomitis. In chronic phase findings, 80 of them had dry eye, 37.5 had trichiasis, 25% had symbliphron formation, 25 had corneal opacity, and also meibomian gland dysfunction, and 12.5% developed punctal autoocclusion. So the visual outcome, only 25% had visual impairment, that was because of corneal opacity formation, and 75% did not have any visual disturbances much. So coming to discussion, Stevens-Johnson syndrome is a dermatologic emergency characterized by the presence of epidermal and mucosal bullous lesions involving less than 10% of the total body surface area. So we have a Stevens-Johnson toxic epidermal necrolysis spectrum, in which if it's less than 10%, we call it as Stevens-Johnson. If it is between 10 to 30%, then it is an overlap of Stevens-Johnson with toxic epidermal necrolysis. If it is more than 30% of total body surface area, we call it as toxic epidermal necrolysis. So causes of Stevens-Johnson mostly is because of drug induced. So we have allopurinol, antiepileptic drugs, sulfa group of drugs, nevirapine and NSAIDs, meloxicam, piroxicam. So infectious causes, we have Mycoplasma pneumoniae, cytomegalovirus, herpes simplex, streptococcus, Yersinia, adenovirus, measles, and varicella zoster. So according to duration, we have the clinical presentation. On day 1, a patient can develop conjunctivitis, subconjunctival hemorrhage, conjunctival membranes. On day 3, conjunctival ulceration, superficial punctate epithelial erosions, epithelial defects. On day 4, there can be symbliphron, ankyloblephron formation, trichiasis, dry eyes on week 5 to 6. There can be punctal occlusion, anterior blepharitis also during week 5 to 6. On week 7, there can be some conjunctival scarring. During month of 3rd to 4th, there can be lid margin keratinization, meibomian gland dysfunction, corneal opacification. And 5th to 11th month, we have dry eye, dystrichiasis, limbal stem cell failure, and corneal vascularization. So during acute phase, we'll have to do prompt ophthalmic evaluation, preservative-free lubricants has to be given, topical steroids, cycloplegics, and bandage contact lens if needed. During early chronic phase, lubrication, anti-inflammatory therapy, symbliphron lysis, tarsorrhaphy if needed. During late chronic phase, immunosuppression, reconstructive surgery, limbal grafts, and topical transretinoic acid. So conclusion, immediate ophthalmic assessment should be standard for all cases upon diagnosis, regardless of apparent severity of skin involvement. A multidisciplinary approach has to be done, and long-term follow-up is critical even after the acute phase to detect and manage late onset ocular disease effectively. Thank you, sir.
So Kritika, good study, 10 cases. For the dry eye, you did the objective or the subjective test?
So we have started the patient on topical lubricants, sir.
How
Regular follow-up, initially when the patient was admitted in the hospital, so it was like, I
Now, how
personally
you
went
confirmed your diagnosis?
dry eyes.
It was mild, moderate, severe?
Yes,
and
sir.
Accordingly, which lubricants?
Type of lubricants.
Okay, thank you. And any more question?
Yeah, Kritika, I have one question. In your cases, beautifully documented, you said in your treatment you use only the medical management,
Yes,
like
sir.
topical steroid
sir.
and all. Was there any cases where like amniotic membrane graftings and surgical management was also required? And what were the sequelae of all those patients? Do they have any scarring or any symbliphron in the follow-up?
So one patient had developed symbliphron, sir. That was very mild. So to prevent the further development of symbliphron, we had done sweeping of the fornices with the glass rod, sir. 2 patients had developed a corneal opacity, sir. And that was not involving the pupillary axis, sir. So vision was not much threatened, sir.
Okay.
Actually, I'll like to ask the same question which Dr. More asked. Was the same lubricant used for all the patients, or did you decide according to the severity which lubricant has to be used?
So we concentrated on the preservative-free lubricants, sir. Apart from that, sodium hyaluronate was suggested for all kind of patients. We had also given gel type, sir, for appliement.
Okay, thank you.
Thank you, sir.
Next speaker, Manaswani Thumma. Ophthalmomyelitis, a rare ocular encounter with parasite larva.
Please restart the timer.
Good morning, sirs. My name is Manaswini. I'm from Regional Eye Hospital, Kannur. Today my topic is on ophthalmomiasis, a rare ocular manifestation with parasitic larva. Coming to the introduction, ophthalmomiasis is uncommon but clinically significant parasitic infestation of the eye caused by fly larvae. The condition does not result from adult eyes. Eastersophis, this is the most common worldwide. Other organisms are like Dermatophobia hominins, Wolferatia magnifica, and Chrysomia bassiana. It may present as external, internal, or orbital miosis with varying degrees of ocular morbidity. Delay in diagnosis may result in vision-threatening complications. Although rare, ophthalmomiasis has been increasingly reported in tropical and subtropical regions in rural India where poor hygiene, livestock rearing, and climatic condition favorites occurrence. Coming to my case description, in this case report, we present a rare clinical scenario of a patient with foreign body sensation, watering, and a red eye. This case emphasizes the importance of considering ophthalmomiasis in patients with acute ocular irritation and redness. Coming to my case, a 24-year-old male, driver by occupation, presented to the ophthalmology outpatient department with complaints of foreign body sensation and redness in his right eye for 1 day. The patient reported that a fly had struck his eye shortly before the onset of symptoms. There was no history of ocular trauma, previous ocular disease, or systemic illness. Coming to the ocular examination, right eye, the visual acuity was normal, globe was intact, orbital margins were regular, eyelids were normal. Coming to the conjunctiva, congestion was noted with freely mobile larva noted in the fornices, 1 to 2 mm long, fleeing from light. Cornea was clear and fluorescence and stain was negative. Other parameters were normal. Coming to my left eye, all other parameters were normal, no significant abnormality detected. Coming to the fundus examination, fundus was normal. B-scan both eyes, there was no retinal detachment or mass or hemorrhage and shows a normal study. This was the larva in the fornix with congestion, conjunctival congestion. And here we can see a freely mobile larva. This is a freely mobile larva. Coming to the treatment, mechanical removal of larva with forceps were done under topical anesthesia. Almost 15 larvae were removed. Moxifloxacin eye drops 4 times a day was given, and ketorolac eye drops 4 times a day was given. Hydroxymethyl cellulase eye drops 4 times a day was given, and at night, moxifloxacin eye ointment was advised. Patient was followed a week later, and symptoms were subsided, and ocular examination was normal. And the removed larvae were immediately preserved and sent for microbiological examination. On detailed evaluation, the specimen was identified as larvae of Eastersorbis, that is sheep nasal boatfly, therefore by confirming the diagnosis of external ophthalmomiasis. This is the microbiological examination report showing spindle-shaped larva with 1 mm in length, with 10 to 11 segments, dark brown, and with anterior hooks. Coming to the discussion, external ophthalmomiasis is most common caused by Eastersorbis, the sheep nasal boatfly, which inadvertently deposits larva in the human conjunctiva. Patient typically presents with acute conjunctivitis-like symptoms, including redness, irritation, lacrimation, and foreign body sensation. Direct visualization of a moving larva on slit-line examination is must. The mainstay of management is the mechanical removal of larva under topical anesthesia. Supportive therapy with topical antibiotics and lubricants helps to prevent superannuated infection and reduce inflammation. Prognosis is generally good if diagnosed and treated early. As in this case, however, delay in diagnosis or deeper infection by larva may lead to severe ocular complications. Coming to the conclusion, early diagnosis by slit lamp examination and removal of larva are critical for preventing complications. Awareness among ophthalmologists and patient education in endemic areas play a vital role in early detection and management. Prognosis is excellent in external ophthalmomyiasis when treated early, but delayed diagnosis can result in irreversible ocular damage. Coming to my take-home message, suspect ophthalmomyiasis when the eye itches after a fly strike. Slit lamp examination can spot what the eye cannot hide, that is a moving larvae. Early removal, that is safe vision. Delay, danger of deep invasion. Awareness, safe side. Thank you. These are my references.
Does the larva remove in a live state or dead state?
In live state, sir.
How do you ascertain the total removal of larva?
Sir?
How do you ascertain the total removal of larva is done? Can there be any remnant larva still there? Or how do you ascertain that? Do you do any testing?
No. Excuse me, sir. Can you please repeat the question? Can you please repeat the question, sir?
My question is, how do you know that the larva you have removed totally? How do you?
Actually, we have done the slit lamp examination, sir, and again we have asked the patient to follow up a few days later, and we again.
Is there any role of ultrasound?
Yes, sir. We did B scan and it shows normal. There was no vitritis or no retinal detachments.
Okay. So your larva, that larvas were on which space of the orbital space? Is it intraocular or is it extraocular? So extraocular, what space was there?
Yes, sir. It was only extraocular, sir, because fundus examination was normal and B scan was also normal. So
Okay. Fine. Thank you.
Any more questions? Next speaker is Dr. Suez Chowji, and the title is A Clinical Comparison of Post-Operative Astigmatism in Suture and Sutureless Glueless Pterygium Surgery.
Good morning everyone. My paper presentation topic is a prospective clinical comparative study to assess post-operative astigmatism following suture and sutureless glueless pterygium excision. Pterygium is a degenerative condition characterized by triangular wing-shaped growth of fibrovascular tissue from bulbar conjunctiva over the cornea. Pathogens include damage to the limbal stem cell and activation of matrix metalloproteinase leading to invasion of the corneal and destruction of the Bowman's layer and superficial corneal lamina. As pterygium advances, it distorts cornea and resulting in significant astigmatism and visual improvement. My aims and objectives are to study the keratometric findings in pre-op and post-operative pterygium cases, to study the correlation of astigmatism with various grades of pterygium, to compare astigmatism after suture and sutureless glueless pterygium surgery. I have included all the grades of pterygium and age of patient above 20 years. I have excluded the patient which have recurrent pterygium, age less than 20 years, any history of ocular morbidity, and any patient having ocular surface pathology with corneal pathology like edema, opacity, previous corneal refractive surgery, and degenerative dystrophies. The study was prospective comparative study conducted in the Netaji Subhash Chandra Bose Medical College, Jabalpur. My sample size was 40 eyes were examined. I have divided the patient into two groups, suture, group A suture and group B sutureless glueless pterygium. Keratometric findings were measured with keratometer pre-operative and post-operative on day 1, day 7 and day 30. Relevant history of diminution of vision, pain, foreign body sensation, redness, photophobia, headache was taken. Any previous surgery history was taken. Associated systemic illness, chronic illness history was taken, and history of trauma also was taken. On ocular examination, visual acuity was recorded. Anterior segment examination was done with slit lamp examination. Results of my study are, in my study shows the out of 40 patients, most of the patients are male, that is 28. In age distribution, most of the patients belong to 40 to 60 years of age. And both the study groups are suture and sutureless. Equal patients are divided into two groups. Most of the patients shows the grade 2 pterygium, which are approximately 28 patients shows grade 2 pterygium. This chart shows the pre-op and post-op comparison of astigmatism with and without suture in study. Highest astigmatism seen more than 3 days after pre-operative, and it gradually improves over time after surgery. On post-op day 30, on post-op day 30, maximum patient showing astigmatism of less than 1 day after. This chart shows the comparison of astigmatism with and without suture. In suture group, pre-operative mean astigmatism was 3.2, which gradually reduces after post-operative to 1.2. And in sutureless group, mean astigmatism pre-operative was 3.2, and which was reduces to 0.9. Most of the patients with grade 3 pterygium have maximum astigmatism. This table shows the visual acuity measured on pre-op and post-operative, in which visual acuity is improved to 6/18, which was due to decreased astigmatism after surgery. In my study involving 40 patients divided equally in 2 groups, astigmatism were measured pre-op and post-operative on day 1, day 7 and day 30. Pre-operative, both the groups shows the mean astigmatism around 3.5 diopter, indicating for surgical intervention. On post-op day 1, patient in the sutureless group had a mean astigmatism of 2.1 diopter, which is significantly lower than the suture group, which has 2.8 diopter. Sutureless technique may reduces immediate post-op astigmatism more effectively. On post-op day 7, the trend continues with the sutureless group showing a mean astigmatism of 1.5 diopter compared to the 2.2 diopter in the suture group. On post-op day 30, the sutureless group had a mean astigmatism of 0.9 diopter, which was while the suture group shows 1.2 diopter. Conclusion. In my study, most of the patients were male. Most of the patients had nasal pterygium with grade 2 severity. Post-operative, there was no recurrence. Study indicated that the sutureless techniques are superior in reducing post-op astigmatism. Sutureless glueless pterygium excision surgery results in less post-operative astigmatism and also improves visual outcome with faster recovery compared to traditional suture technique. These are the references.
Dr. Suyash, what is the novelty in this study, because there are so many studies like this?
Yes, sir.
Okay, now coming to the astigmatism, so what was the follow-up and it reduced to which level?
Sir, it has reduced on post-op day, it reduces slightly.
So you have taken only post-op day 1
day 1, day
astigmatism.
7 and day 30, sir.
So what was it day 30?
Day 30
average?
Gradually reduces, and it has a 0.9 diopter astigmatism in suture group, and sutureless it has a 1.2 diopter showing in mean.
So you were able to do keratometry in the grade 3 also?
Yeah,
Because
sir,
sometimes
grade
it is
three
not
difficult,
possible.
Sir. Yes, sir, it's so difficult. Sometimes it shows no target only.
Okay.
What type of astigmatism was seen on all your cases? Is it with the rule or against the rule?
Sir, with the rule astigmatism.
With the rule astigmatism.
Yes, sir.
And suture, usually you use observable sutures.
Yes, sir.
Yeah, usually they get observed in a month, 6 weeks times.
Yes.
So what is the rationale or the hypothesis behind getting astigmatism reduced with suture and sutureless?
Sir, with suture it has some tension, and it shows that sutureless is better than suture.
So how is better use?
Sir,
Sir is asking how this suture affect the astigmatism.
sir, it causes tension, and so astigmatism is more than.
Okay.
Thank you, sir.
Any more? Any question?
Thank you, sir.
Thank you.
Thank you. Next speaker is Banka Mega Ajay, and the paper is the tarsal puzzle, diverse diagnosis and
Check.
surgical approach for tarsal related cyst.
A very good morning. Every time a patient with an eyelid lump or bump walks in, most of us would start looking for signs of a chalazion, and more so start hoping for no signs of an eyelid malignancy.
IT people. Is it a puzzle? And please reset the timer also. Make it 5 minutes.
Okay. So every time a patient with an eyelid lump or bump walks in, most of us would start looking for a signs of chalazion, and more so start hoping for no signs of an eyelid malignancy. But beyond these two possibilities lies the spectrum of benign tarsal related cysts. These include a range of different types of benign epithelial cysts which share clinical similarities, are anatomically related to the tarsus, but have minor histopathological differences. Our pathology colleagues rely on some striking clues like the gross and microscopic appearance of keratin, the lining epithelium, amongst many others before they stamp their reports. But as clinicians, the only differentials that is relevant to our management are a chalazion and a malignancy. A malignancy will have a completely different picture with loss of eyelashes, meibomian gland dropout, distortion of eyelid margin, amongst many others. The challenge lies in differentiating a benign tarsal related cyst from a chalazion. In all fairness, even the best of us can easily confuse these well circumscribed progressive smooth lesions fixed to the tarsus as chalazion and treat them with an incision and curettage only to end up with a recurrence. But definite clues like lack of inflammation, slow growing, soft to firm, fluctuant eyelid lesions within tarsal height with no response to antibiotics and a delayed recurrence are the holy grail to tell them apart from a chalazion. We present to you a retrospective consecutive interventional study of 53 histopathologically confirmed benign tarsal related cysts which assessed the entire spectrum, explored preferred surgical techniques based on cyst base and involved tarsal thickness, and gives definite ways to reduce recurrence. We found no sex predilection in our study. The patient profile included majority of them in the 4th to 7th decade with a mean age of 52.7 years. Where 85% of them were gradually progressive. 100% of the lesions were well circumscribed, smooth and non-tender with no signs of inflammation, of which 45% were soft and firm each. 82% of the lesions were mobile, while 18% showed tarsal fixity, either with a yellowish-white nodular bulge or bluish discoloration on eyelid eversion. From a detailed analysis of our cohort, we suggest the following surgical algorithm. We begin by assessing the lesion's prominence on either skin or the conjunctiva to decide on a skin or conjunctival approach respectively. Then we assess the cyst base with involved tarsal thickness. If the lesion has a large base, the involved tarsal thickness will not matter. But in case of a small base with no tarsal fixity, smooth cyst excision works best. For a superficially adherent tarsal cyst, excision is augmented with partial thickness tarsectomy. And for a small cyst with full thickness tarsal involvement, cyst excision with full thickness wedge tarsectomy gives the best outcomes. While in case of a large base, a full thickness tarsectomy would leave a huge tarsal defect. Hence, marsupialization works best, which essentially means exteriorizing the cyst base. Augmenting marsupialization with either cryotherapy, cautery, fulguration or alcohol ablation or any combination of the above to the base to eliminate any residual cellular lining helps achieve close to zero recurrences. This is a summary of the preferred surgical techniques used to manage our cases. The histopathological distribution of our cases revealed majority of them as epidermoid cysts followed by inclusion cyst, retention cyst and intratarsal keratinous cyst. These are some outcomes of our patients with excellent aesthetic, functional results and minimal risk of recurrence. Ours is the first study to review these lesions with the longest follow-up period of about 75 months, which concludes how despite histopathological variations, a clinician can use an algorithmic approach of surgical techniques based on tarsal base and involved tarsal thickness to achieve optimal results. As the third most common tarsal lesions, these benign epithelial cysts warrant a high degree of suspicion. Despite the glaring similarities with the chalazion, a keen eye for the differentiators can help to tell them apart. Always rule out a malignancy first. A methodic, algorithmic surgical approach based on cyst base and involved tarsal thickness can provide gratifying results for the surgeon and the patients alike. Thank you.
Excellent study with a great sample size, and the follow-up is also good. So LPS, so it was how many cases you requires to reattach
3 cases.
out of 53?
Yes. We have to look for that when we are operating, and in case that is involved during the excision, then it has to be reattached.
Any more question? Thank you.
Thank you.
so much. Dr. Sarab Chabra, the next speaker. He'll be speaking on amniotic membrane for repair of spontaneous scleral melt in Marfan syndrome.
Good morning, everyone. Thank you for being here for this morning session. I would like to present an interesting case and an interesting management before you of usage of an amniotic membrane for the repair of a spontaneous scleral melt in a patient who presented with Marfan syndrome. This was an adolescent male who presented with a gradual progressive diminution of vision in both eyes since the past 8 years, worsening over the last 3 years. There was no history of ocular trauma or surgery. Visual acuity at presentation was 6/60 both eyes, best corrected to 6/24. IOP of both eyes was within normal limits, and as expected, the older brother had similar complaints. On ophthalmic examination, the anterior segment had iridodonesis with loss of peripheral crypts. The pupillary area was partially phakic, partially aphakic. Superonasal lens subluxation was visible with phacodonesis, and there was a myopic fundus with no peripheral treatable lesions. On general examination, all the features were suggestive of Marfan, such as a tall stature, long face, thin fingers, and increased arm span, and the cardiologist reports showed a mitral valve prolapse with moderate regurgitation. As there was no refractive improvement, a bilateral pars penal lensectomy with anterior vitrectomy was planned with suturing of the incision site. Both eyes were operated by the same surgeon. The left eye was operated after the right after a gap of about 10 days. The post-operative course, the right eye was thankfully uneventful, but the left eye was far from that. On post-op day 0 in the evening, the cornea was clear. There was a 1 millimeter hyphema. The pupil was round, but the peaking had just begun, and the IOP was low. On post-op day 1, peaking had increased, hypotony was observed, and similarly the disease progressed on day 2 and day 3 with severe hypotony noticed and spontaneous scleral melt posterior to the surgical wound site. The patient was taken up for emergency surgery. Intraoperatively, scleral rupture with adjacent areas of thinning was noticed, and underlying uveal tissue was visible. All the abnormal overlying thin conjunctiva was excised, and an live amniotic tissue graft measuring 26 by 8 millimeters covering the entire area of thinning was implanted and secured with 8-0 vicryl sutures. For post-op medication, the patient was advised topical and oral medication including oral steroids, tapering doses starting with 1 milligram per kg body weight, along with fortified topical antibiotics, cycloplegics, lubricants, and oral cyclosporin 50 mg twice a day. These are the post-op day 2 images. The eye was stable, the graft was in position, and the visual acuity was 1/60. And thankfully, at 1 week of follow-up, the globe was stabilized, the graft was well taken up, no recession was noticed, and the IOP was maintained. At 6 months, the scleral wound and the site of rupture were stable along with the conjunctiva over it. Best corrected visual acuity was 6/12. Highlights of Marfan's: it is an autosomal dominant disease affecting fibrillin gene present on chromosome 15. This abnormal fibrillin causes axial myopia, scleral thinning, and mechanical stretching, which leads to progressive rupture and perforation. There have been few reported instances of spontaneous scleral perforation. Generally, scleral thinning, the most commonly used methodology for treatment is scleral patch graft, and there have been a few reports of late dehiscence of a sclerotomy in patients of Marfan's. In this case, there was no recurrence noticed over a long-term follow-up, and amniotic membrane is a good candidate for such patients as it lacks immunogenicity, promotes epithelial growth, and has high regenerative capabilities, much more than scleral patch grafts. Thank you so much for your time.
So excellent case this. So now coming to the AMT, so was it freshly prepared?
So the amniotic membrane, sir, it was a live amniotic membrane. The institution has a high number of obs-gynae loads, so a live graft was available.
Okay. And now coming to the last follow-up. So vision was 612, the peaking was there. So why not you went for the 4th row pupilloplasty to make the pupil round and regular?
So the patient was satisfied with the visual outcome. So the patient is still on follow-up. Once we are sure that there is no recession and there is no chance of any the recession.
Vertically, what was the means? It must be a 6 millimeter optic size only. The IOL.
Yes. Yes, sir. Sorry.
Optic size was 6 millimeter only, no?
Yes, sir.
So little bit of phakic area was visible.
Yes, sir. But the patient was satisfied with the vision, as that portion is usually covered with the eyelid also. So.
Okay.
You have used suture.
Yes, sir.
For tucking the amniotic membrane. Why
Yes,
not you have used glue, which would be better result?
Sir, in this case, the first consideration was the saving the integrity of the sclera. So at that time, sutures seemed the best, and so using sutures had the best probability of the graft not moving around with a long term, the graft being held in place long term. So as it was an emergency surgery, sutures were the first choice.
Is it sterile scleral melt or infective scleritis?
Sir, sterile.
Sir, how do you know? You have done any testing for that one?
Unfortunately.
Microbiological testing was done?
No, sir.
No.
Thank you. Excellent case. And the finalist for the Dr. Nupur Gupta? Yeah, please.
Good morning, dear experts and members of the House. I'll be presenting our findings of the ocular surface microbiome in patients with breast cancer. We all know that ocular surface microbiome is a paucibacterial microbiome as compared to the gut microbiome and the buccal mucosa. Its dysbiosis can lead to ocular disease, and it is commonly deranged in patients with dry eye disease and meibomian gland dysfunction. With this in mind, we studied some patients with breast cancer who have been reported that there's a lacunae in literature of their having ocular surface problems and disruption of their ocular surface. So patients on systemic therapy for breast cancer were included with the rationale of studying their ocular surface microbiome and a non-invasive way to study their dry eye disease through the ocular surface analyzer. So the primary aim of the study was to characterize the ocular surface microbiome in these patients undergoing systemic therapy in the form of chemotherapy, hormone therapy. And the secondary aim was to do ocular surface microbiome and correlate with the dry eye parameters, including ocular surface disease index questionnaire, the non-invasive breakup time, lipid layer thickness, tear meniscus height, and meibomian gland dysfunction, including meibography. So patients of breast cancer were recruited from the surgery department of All India Institute of Medical Sciences, New Delhi. They underwent a comprehensive ophthalmic examination, including a complete dry eye workup. Conjunctival swabs were taken from the inferior conjunctival fornix to isolate DNA, and then ribosomal RNA sequencing was done, and bioinformatic analysis was done to find out the metagenomes present in the ocular microbial flora and to determine the diversity and their richness in the conjunctiva. Nearly all patients fell in the age group of 39 to 70 years. They were basically from two stages of the disease, stage 2 and stage 3, and there were equal distribution of the treatment naive group, the hormone therapy group, and the chemotherapy group. When we looked at the dry eye parameters, it was surprising to note that the non-invasive breakup time was deranged in all the patients. It was less than 10 seconds. all patients did present with some degree of meibomian gland dysfunction. The tear meniscus height was also disrupted, and they showed an evidence of low lipid layer thickness in these eyes. So these were the objective findings that we picked up, and on meibography also there was a meibomian gland loss. So when we studied the ocular surface microbiome, the three groups that were studied were the chemotherapy group, the hormone therapy, and treatment naive, that is NT group. They showed all a richness, increase in richness, but the chemotherapy group had a decrease in the count of bacterial load and also in the diversity of the microbiome that was present, as is evidenced by these three charts. So the NT is the no treatment or the treatment naive group, HT is the hormone therapy group, and this is the chemotherapy group. The chemotherapy group depicted that there was a staph epidermidis rich microbiome with an increase of Klebsiella and Corynebacterium, which was not seen in the no treatment group, where there was a decrease in staph epidermidis and an increase in a virome genome, which is lymphocryptovirus human gamma 4, and this showed that chemotherapeutic agents actually change the microbiome and decrease the richness. So to conclude, the ocular surface microbiome profiles of patients of breast cancer under treatment show a core community which treatment, and there is a shift towards a dry eye disease composition, and patients receiving chemotherapy had reduced ocular microbiome diversity dominated by one genus, that was staph epidermidis. And all therapies do impair the ocular surface that could be related to the ocular surface disease that is present in these patients. And these findings could then be used to develop longitudinal cohorts with pre and post-treatment sampling. And more functional studies are recommended to determine causality. And we could explore the role of microbiome-targeted therapies to improve the quality of life and decrease the dry eye and ocular surface symptoms due to this disease and the therapy. Thank you.
This very unique study. So now coming to the average age was around 60 years.
Yes, sir.
So the phyla, the bacteroids and the Prevotella. So Prevotella increases after 60. So because of the chemotherapy, was there any variation in these phyla?
Yes, so usually the main constituents of the core ocular microbiome in normal flora is usually Corynebacterium, and here we saw more of staph epidermidis, which more or less corroborates with patients who have dry eye disease and meibomian gland dysfunction, and they were less diverse as well. So probably the chemotherapy reduced the bacterial flora because they have a direct impact on the microbial flora. Other patients, like on hormone therapy, showed a more diverse microbiome like we do see in dry eye disease and limbal stem cell deficiency also.
And did you consider the role of diet or the FMT when they derange this RNA sequencing in the extreme of the dryness?
Role of diet?
Diet, yes, of course.
Yes, the role
because
of
gut microbiome does affect.
So this is the ocular surface microbiome, and diet may have a role, but these patients were all similar age group. They were postmenopausal females. That definitely could be a confounding factor.
Any more question?
Thank you.
Very unique study.
So with that, we come to the end of this the session, and thank you all the speakers, very well presented, and all has a very unique and very rare cases. And thank you all the chairman and co-chairman and the judge over here. And at the end, we'd like to have one group photograph. The marks will be later on given to the committee. Okay.
So can we have all the speakers for a group photograph, please?
Sir, please. आपका जिम्मेदारी. मेरा